it goes longer, I can also table SAMs for the next week. It's not a big deal.
Okay, well, shouldn't go long, but I always think it's not going to go long, and then someone reminds me that it's going long. So you let me know when you think we should get started. And can you elevate the residents who I can call on? And APPs. Is Ted here? I don't see him.
No, either do I.
Chris, do you know the status of the USMLE? What's USMLE Part 2? Has that been suspended?
I don't know. Yeah.
Because I heard from one of the external rotators, one of the international medical students who had rotated with us, who wanted to do the PRF program, say that there had been a suspension of USMLE.
It's of the clinical skills component, the one where you have to do the patient exams.
I don't know which component it was, but what I understood was that she could not get the credentials she needed for our PRF program because of that suspension.
Yeah, it seems that the clinical skills component has been suspended.
Oh, is that right, Ernest?
Yeah.
Oh, yeah, that's what she said.
That's
USMLE
half of step 2.
Yeah, clinical skills for 12 to 18 months due to the pandemic. Boy, that's a real impediment to someone who's outside who could otherwise come to one of our PRF slots, isn't it? Well, it just goes to show how important this program is. I think it's gaining a lot of traction internationally, and very, very happy with it. Okay, I think we should get started. I have a case that I would like to share, a recent case. I don't have the films. So you should be seeing, I'm hoping this time just to be sharing my PowerPoint. Is that right?
Yep, was good.
Okay. This is a left posterior fossa approach to an epidermoid, a patient who we had on the service up until yesterday. The surgery was last Thursday. And so this is just going to be another posterior fossa surgical anatomy discussion, which by now should be trivia, nothing but trivia for you guys. Now I don't see, let me see if I can. Okay. So you have elevated the residents, is that right?
Yes. They're listed as panelists with video on.
Now they're in the panelists. Okay, great. All right, so if this is the left side, Abhi, then what is the structure that I'm pointing to here? And in general, what is this structure that I'm pointing to here? The white, not the yellow, the white.
All right, if that is the left side, then the one on the right would be the tentorium.
Right, correct. And
Mhm. The one on the left would be the I guess the petrous.
that's right. Okay.
Um,
And so then this junction here, we like to call what? Not the vascular structure, but the junction.
I guess petroclival. Would that petroclival?
Well, you've got Petro, right?
Mm,
And so if
uh,
there was a tumor arising from this area here and then extending immediately, that would be called a petroclival meningioma. But we call this the petrotentorial junction. And running through the petrotentorial
got it.
junction, Alejandro, is what? What vascular structure runs through the petrotentorial junction? You there, Alejandro? I see you there, but I don't hear you. Alex?
The superior petrosal sinus.
Sinus, right, okay. And therefore this vein would be what?
The superior petrosal vein.
Good. All right. Is the superior petrosal vein something that can be sacrificed?
Yes.
Okay. So how are you going to do that?
I'm going to follow it to where it gets to the tentorium. Make sure I have a safe plane with enough vein separating from the tentorium and cauterize it away from the tentorium so I have a good edge of the vein to cauterize.
And then what?
Then after cautery can sharply cut it.
Okay. Ernest, any tricks that we have spoken about when you cut this vein, how to do so?
Yeah, I recall that we want to make sure that if it continues to bleed, we're able to continue controlling the bleeding. So we want to be away from the junction of the vein. So cutting, I guess, about midway of its course, so that we can still see the edge of what we've cut.
Okay, that is definitely true. What else? What other tricks? Frank?
If you do bipolar it, I would only want to cut it halfway, make sure that it doesn't continue to bleed, and I wouldn't want to go full thickness cut.
I think that's the key. And the reason is this arachnoid here. So it's a fairly large vein. And if you, even though it may look completely collapsed after you've coagulated it, if you just cut all the way across it and it's not fully closed, which is often the case, it will snap down underneath this arachnoid here. It'll just disappear from view completely and retract like a shade, a window shade. Now here I've opened a little bit of this arachnoid, but often this arachnoid will completely cover. You coagulate it here and then you make the mistake cutting all the way through, and it then retracts down behind here, and now you end up with a large subarachnoid hemorrhage because you can no longer control it. So that last point that Frank made is one that I perseverate on every single time we do this. Yes, you cut far enough away, and you're almost never far enough away from the petrotentorial junction. And then you cut halfway through first. You could even do a Valsalva if you want, and then finish it off before you finalize cutting it, because it'll retract and instantly disappears. Okay, so then we're gonna do that and continue our journey medially. Halima, so ignore all the colored lines here. You've got these nerves over here. You see a brainstem entry point of these nerves over here, and you've got just a mountain of white over here. But this looks a little different. So what do you think we're looking at?
So towards the left, we are looking probably at the fifth trigeminal.
This one?
Mhm.
Okay, then what would this one be?
So that also looks like a nerve.
Agreed.
So it's, and then the tentorium. So one of the lower cranial nerves. It's this.
Well, what is this? What is this flat structure up here? Let's just go back once. So we've got this flat structure up here.
The tentorium.
So this is the tentorium. Then you've got this nerve here, and you've got this here that, as you said, looks like a nerve, and it's closer to the tentorium than this. Do you want to reevaluate your model?
Closer to the further up. So if the so then the one on the right side would be the fifth, and the one on the left side would be the seventh, eighth.
Good.
Yeah.
Good. So what you just did there, and you know, I try to have patience while you're rotating this in your mind. But what you just did is the most important thing that you can do during surgery, which is to look at what you see and realize that it doesn't fit the model, the mental model that you've constructed to interpret where you are. Is incredibly important, and it's very painful and difficult, because once you lock in, I've seen this over and over again. We've seen it, 100 times this year. Once you lock in to a model and you operate on that model in which this is the fifth nerve, it's very hard to get out of that, and you can make very serious mistakes based on an erroneous interpretation. So it's as difficult as it is, it's good to be flexible enough that you can reinterpret your model based on new cues that come in. You need to have a model, a working model. You can't operate blindly, but you want to be constantly questioning yourself as to whether that's the correct model, and you did. So this is the fifth, and this is 7 and 8. Excellent. Okay. So now we're still back up at the tent over here, and this is tumor. What vessel is this then? If this is tumor and this is the tent, and we're separating, then what vessel is this? We can go to the next person who looks like that's going to be Jacques.
Could be the PCA.
Could be.
PCA.
It could be the PCA because it's posterior, but we're below the tent. So if it's not the PCA and we're below the 10.
PCOM.
Okay. Well, that's not totally outlandish. It's going in the, PCOM goes from back to front. But again, we're below the tent. And we're on the lateral aspect of the brainstem over here.
Okay, the superior cerebellar.
Okay, superior cerebellar. That's a little better. And so we have to separate the tumor from the superior cerebellar. So moving on, as we get past the superior cerebellar and we get further medial, we see this white structure peeking down. And Jeff, what is that going to be?
It's going to be the
looks like the fourth.
Okay, you're both Jeff, and you're both right. That's good. You're betting 200% right there. And so where does so that was good for Jeff Gilligan. So Jeff Simmering, where does the fourth enter into the cavernous sinus?
Laterally from posterior to anterior.
That's exactly right. And you see the entry, you see the tent hiding its entry point into the posterior lateral cavernous sinus right over here. Okay, so with that in mind, Ray, there's another white structure coming into view beyond this arachnoid here, and what's that going to be?
Is that the third?
That's the third. And that's exactly right, because you're going to be in this territory. We saw the superior cerebellar artery. We're going medial to third. We're looking up and medial into an arachnoid through the arachnoid here. So that's going to be the third. That's exactly right. Okay, so now we're going to turn our attention inferiorly. And we've already identified these as 7 and 8. So what vessel then is going to be coming out hidden by the brainstem and the cerebellum and coming out with a branch feeding going up into the internal auditory canal from below? Travis?
It would be AICA with a labyrinthine artery going out laterally.
Exactly. Exactly, 100% right. Okay, so then we're going to need to get this tumor off from the 7 and 8 complex. And as we're doing that, another white structure comes into view. So Trevor, what do we think that's going to be?
Inferior to 7 and 8. That white structure on there we might think would be spinal accessory bending down.
Okay. Well, you are right if you're thinking in terms of rostrocaudal anatomy. But what about medial-lateral anatomy? If you look,
it could be 6.
Yeah, that's right. Because our focal plane here is out lateral, and you can see 9 and 10 where my point is, right down low in this plane. But we're diving way, way deep, and you see a couple of things that make you think this is 6 rather than 9, 10. One is that 9 and 10 are a network of small nerves that are darker in color. 11 is typically quite white, but 9 and 10 are darker in color. And 6 is usually the brightest, whitest nerve of them all. And we see that it's going from front to back rather than from down to up. So you've got the fact that it's deeper, it's in between these two nerves, it's brighter, it's a single fascicle, not lots of little ones, and it's going from front to back. Those are all cues that help you make you think that it's 6, and then you can confirm that as the dissection continues. Okay, so we can go back to the top. And Chris, I'm almost done, so I don't want to hold you guys too long. Abi, I'll just point and you name them. All right?
Six, 7, 8.
All right. Well, what about this versus this? Which way? What is the order of things going to be for 7 and 8?
So 7 is going to be deeper than the 8.
Right.
From what we're looking at.
That's right. And Alejandro, did you get back on, or are you not with us?
Yes, sir. I'm with us.
Have to mute. I think so Alex, in terms of color,
Sorry, sir. There's a lot of echo. I'm having a hard time hearing you.
Alejandro, you need to mute yourself.
Alejandro, can you?
What did he say?
Can someone please mute Alejandro?
I'm trying to, but I can't.
Okay.
Okay, there we go. Well, Alex, can you hear us now? What
Yeah, yes, sir, I
what is
can.
the color difference between, if you don't know the position or the position is distorted, is there a color difference if you're trying to differentiate vestibular or 8 versus 7?
I believe vestibular is lighter than 7.
That's right. Almost always it's a little bit more transparent and a little bit darker. Okay, and then, so this again is which?
5.
5, right. And this is what?
SCA.
Nope.
Or, sorry, AIK.
Nope. Just back up a second.
Okay.
Let's think of all the characteristics of a blood vessel that you're going to use to determine what it is. Color, size, direction, branches, and location. Okay. So compared to the SCA, this is lighter, isn't it? What we saw before was dark red. This is light. What would make a vessel look lighter?
If it was blood.
Okay, you're thinking in terms of oxygenation. That's true. A vessel that's filled with more oxygenated blood is going to look lighter than a venous one, but we're looking at arteries now. And so another thing is going to be the thickness of the wall. So thickness of the wall is going to make it look lighter. A really fine vessel is transparent, so you can see the true color of the blood. And this is a very large vessel. This is almost as big as the fifth nerve. So it's lighter, it's bigger. Let's think of all the things that we have to help us here. It's medial to 5, it's medial to 6, 7 and 8, and it's going from down to up. What other information do we have? I'm sure you know what it is now, but now I want to focus on the information that you're going to use. So what other information do we have here that we can call on?
I mean, we can look in the direction of flow. Also, its location relevant. Again, you said the direction, which I think gives it away in this case.
Okay. Here's another piece. Someone thought this was big enough that on the navigation they painted it. And so as time passes, I'd like you guys to start incorporating information that I am getting now from the heads-up display that I find extremely useful throughout an entire case. I've learned to accommodate the offset. So here's an offset of about 2 millimeters. But this is a big enough vessel that you would see it on a CTA or an MRI. It's labeled, and clearly it's going from down to up, and it's a single large trunk. So you've got size, location, depth, and that makes it the
basilar sphere.
That's right. Okay. Now you see that there's a junction here, and so what is this vessel going to be?
Be the SCA.
Nope.
Or sorry, the PCA.
Nope. Remember, we're looking from the left side, so this is below.
Oh. Sorry, the vertebral artery.
That's the vertebral artery, that's right. Okay. So left vertebral, PV junction, basilar, and you're going to start seeing paramedian pontine perforators here. All right, Chris, I think that's probably enough, right? We can keep going. Let me just see if there's anything.
2 minutes left.
Okay. We've now shifted our view, looking from down to up. And so we're just cleaning up at the end here, and that, Alex, you can stay. Let's go to Ernest. You're next, Ernest. This one again?
4. Under the, oh no, you're pointing.
Okay, so let's go back to, it was 4 before, but now we're getting more information. First of all, it's gigantic compared to what you should
Yeah, it's
expect.
thicker. Okay, 3 there.
3, exactly.
Yeah.
Okay. Now we have an endoscopic view, and you can see the orientation of the endoscope. So this is a bonus question. I'm going to go all the way down to Travis on this one. So what are we looking at here, Travis? I'll point, you speak.
Basilar. That one is that third nerve.
That's the third nerve. So what do we want to find here in order to complete this picture? How are we going to know that it's the third nerve, and how are we going to know? Just confirm what is the anatomy that never changes? It's always constant as to where the third nerve comes out relative to the vasculature.
You should see it coursing between SCA and PCA with the SCA caudal.
That's right. Okay. So this is our orientation, which means, and you can see that the nerve's going this way. This is going to be the tentorium up here. This is going to be the basilar, and then this should be SCA, a small branch of SCA going on the opposite side. And we see the beginning of the SCA over here. That's my interpretation of this. Does anyone else have a different interpretation? I think that sounds about right. It's a 30-degree scope, and so I think that's probably the best way to interpret it. Probably the endoscopic surgeons like Costas would have a better understanding of this. Okay, I think that's all I have. Good. It's trivial now, right?
So we'll move on to spine conference. We have Jeff Gilligan, one of our outstanding PGY6 residents. Jeff completed an enfolded spine fellowship last year, and he will be talking to us today about spinal oncology.
Hi, good morning. All right. Can you see my presentation okay? Okay, great. So I'll be talking about spine tumors today. I think it's been some time that we use this in the spine conference. I think it'll be a good topic. And as always, I'll kind of pepper in some questions board style for the residents and try to incorporate some of the cases that I've done. So when talking about spinal tumors, we also, in our differential, we always want to describe their location. So they can be extradural, intradural, extramedullary, and also less rare, intradural, intramedullary. In your differential for extradural, you should always think most likely metastatic first, so the vast majority, but it can be lymphoma, breast, lung, prostate, usually kind of in that percentage order. They usually are found in the lower thoracic lumbar area because that's the highest concentration of red marrow. And in thinking of these types of tumors, if they're potentially surgical, you should kind of know which ones are bloody or not. So this is what that question kind of alludes to. And Abhi, what tumors would you consider to do a pre-op embo to help reduce blood loss if you're doing a resection?
Something like Angioblastoma would come to mind. Also, any kind of a vascular lesion, including AVM.
Okay. I'm specifically talking about metastatic tumors right now. Those are fine.
So for metastatic tumors, melanoma and also renal cell carcinoma would have tendency to bleed, even though they're not the most common that would metastasize.
Okay. Yeah, so similar to cranial mets, the lesions that tend to bleed the most: melanoma, renal cell, chordocarcinoma, thyroid, and liver cancer, hepatocellular, and breast and lung to a lesser degree. And then there are also primary spinal tumors that are less rare, including chordomas, bone lesions, intramural bone cysts, as well as vertebral hemangiomas, as well as miscellaneous multiple myeloma, plasmacytoma, etc. And then so for intradural extramedullary, you should always first think either schwannoma or fibroma, but they can also be meningiomas. These have a higher female to male ratio and primarily found in the thoracic spine. And then these other tumors to less extent. And then finally, intradural extramedullary. 60% are usually Pandemoniums, which can be found usually cervical area, and the different types are listed there, as well as conus, which is maxillopapillary, and to a lesser extent, astrocytomas. And then these other tumors, angioblastomas, epidermoids, lipomas, and cavernomas to a lesser extent. Pandemoniums, slow growing, peak into 30s to 60s. If they are found, you need to do MRI imaging of the entire neuroaxis because there could be potential seeding. And in comparison to astrocytomas, these are more central, more uniform, dense enhancement. And the treatment is resection. Alex, do you know what syndrome these can be associated with?
NF2.
Great, nice job. And so next, astrocytomas, a little bit younger age group, and then the most common spinal tumor found in children. Low grade is a 3-to-1 ratio to high grade. And in comparison, thoracic is the most common for these tumors, and then cervical. And compared to ependymomas, they're a little bit more patchy and ill-defined in their enhancement. If it looks like it's low grade, you try to do a full total resection if there is a plane. For high grade or low grade without a plane, you try to do a kind of an extended biopsy, and then we'll afterwards do resection plus or minus chemo. Let's see. Matt Carr, if you're on, do you know what this pathology is and what is it pathognomonic for?
I think Matt's on vacation, Jeff.
Oh, okay. Halima, how about you?
So it's multiple nerve sheath tumors.
Yep.
So
Good.
neurofibromatosis type 2.
It's actually plexiform neurofibroma, but you're close. This is associated with NF1, and it's a 50% association with malignant nerve sheath tumors systemically. Here's kind of a board's question. 13-year-old boy presents with this right-sided scoliosis with severe back pain that wakes him up at night. You see the x-ray there, as well as a CT of L2. We'll say, Ray, what would be your choice for treatment for this boy? You can kind of describe what you see and why that would be the treatment.
Yeah. Okay, so looking at the standing x-ray first, I do see the right-sided thoracolumbar scoliosis, and the CT axial lower down showed, I mean, I'm not quite sure which level that is, but it shows like a hypodense lesion in the lamina. Part of it is in the pedicle of the vertebral body on the left side. So I think that's most consistent with the osteoid osteoma, and the initial treatment for that is NSAIDs.
Perfect. Nice job. Some people can get led astray to seeing the scoliosis, but this is scoliosis due to this painful lesion, and the treatment, as you said, is first NSAIDs and observation. So going into some bony lesions, you can have osteoblastomas, which are a little bit larger than osteomas, osteochondromas, and hemangiomas. I just have some pictures there for those differentials. You can also have eosinophilic granulomas that are usually in a pediatric age group. Aneurysmal bone cysts, which you always see basically this this fluid level that kind of gives it away for those lesions. And finally, chordomas, which we can see both in the clivus as well as sacral interval. And here's just a chart of all those different bone lesions, benign and malignant. All right, we'll go back to, actually we'll go to Trevor. This is a 45-year-old male, renal cell cancer, currently on chemo. He presents to your clinic with a C2 body met with neck pain. He's neurologically intact and there's no cord compression. What would you say the best appropriate treatment is for this patient?
So for a isolated net in the C2 body and neck pain, I would go initially with a stereotactic radiosurgery.
Nice job. So we'll kind of go through this question of kind of why the different other answers are incorrect. Do you know why conventional XRT would be inappropriate in this case?
So the sorry, cut out there. You said why are the other ones not appropriate?
Yeah, we're starting. So I'm starting with A for conventional radiation therapy. Why would that be inappropriate?
I think it's just not targeted. It's not, you're going to be exposing to a much higher dose, and it's not going to be effective.
Exactly. You don't want to use conventional radiation for radio-resistant tumors. And then kind of alluding to that, what would be some other, so in addition to renal cell cancer, what are some other radio-resistant tumors?
Other radio-resistant tumors could be melanoma, is radio-resistant. Mm-hmm. Also, let's see.
Good.
Yeah, melanoma is a big one. Sarcoma.
Yeah, nice job. All right. And I'll kind of help go through these. So surgery is inappropriate, obviously, because there's no cord compression or the patient's neurologically intact, and no additional therapy is wrong because, it's patients have progressive disease and you want to have some local control if possible with SRS. We discussed SRS, and basically it can improve neck pain and provide good local tumor control. The maximum tolerance of radiation is about 10 to 14 grays. All right, Alex, I'll go with you for this one. 47-year-old woman presents with bilateral paresthesias, neck pain. Here's her cervical MRI. And importantly, the sequences that are shown is just a T1 on the left and a STIR on the right. Based on these two images, are you able to give the likely diagnosis?
So it's T1 hyperintense and hypointense on T2.
Mm-hmm. Could you also describe its location?
Yes. So it's a dorsal tumor spanning between C2 and C6, C5. Looks like I would need axial cuts to better delineate, but it looks like it's dural based. It appears that there are dural tails on the rostral and caudal ends of the tumor. For that reason, it doesn't look intrinsic. It doesn't look intramedullary, so it doesn't look like it's a spinal cord glioma. It also.
So is this intradural or extradural?
So it looks intradural. It looks intradural extramedullary.
Excellent. Good.
So based on the T1 and STIR sequences, looks most likely like meningioma.
Okay, we'll go through it because this is a tough one. So it's actually lipoma. So we'll kind of go through it because I wanted to kind of go through this. So what's bright on T1?
I think it says it on there. But fat, fluid, or...
So I guess I'm asking on T1, what is fat? Is it bright or not?
Oh, sorry. That would be dark, and fluid would be bright.
So fat, you can see right here, is going to be bright.
Right.
Fluid's going to be dark.
Fluid dark.
Okay. T2, we're going to do both are basically bright. And then on stir, so we already kind of know the answer, but fat is going to be dark and fluid's going to be light. So if you kind of know those facts, that kind of makes this question pretty easy, that this is going to be lesion made out of fat. We already discussed intradural with that, but out of those choices, that's how you come to lipoma for that. So kind of just knowing what's going to be bright and dark on these sequences can really help with these differentials. All right, we'll kind of go through some of those ones. Abi, based on this imaging where we have T2, T1, and T1 plus, what would you first describe the lesion and then give us your highest differential?
All right, describing the lesion. So this is a lesion of the cervical cord causing pretty significant cord compression, ranging from C2, 3, 4, 5, actually C2 on C3 mostly.
So Abi, just to speed things up, we can see it's in the cervical. I just want you to basically focus on intradural, extradural, intermediate.
Oh, okay.
I just want you to focus on that type of location.
Oh, it sounds good. Okay, so this looks like lesion that has an intramedullary invasion. So I would call it intramedullary lesion, based on the T2 and T1 with contrast.
So I'll help you out. There's no this is intradural, extramedullary, and based on its appearance, what would you give a highest differential?
Meningioma versus neurofibroma.
Close. Those are on the differential, but schwannoma should always be on your top of your list for that location. And I just want to kind of stress that intradural, extramedullary part, because that should already in your mind have this differential out. Okay, so that we'll kind of keep that in mind going forward. So for that same patient, Abi, I'll still go with you. What condition might this person have if you see this is their whole spine?
So they might have neurofibromatosis type 2.
Okay, great. And so what's the gene and the locus?
So that'd be chromosome 22, and the genes are Merlin, NF2 gene, yeah, chromosome 22.
Autosomal dominant, and then other tumors that they're risk for is vestibular schwannomas, which you can almost see on the top of there. Okay, so just know that kind of like the back of your hand for those. All right, Halima, can you describe this location and give us our differential?
The intramedullary lesion spanning from C2 down to about C4, and it's contrast. It enhances on contrast.
All right, so intradural, intramedullary. So what's the highest on your differential for that? Based on, I'll help you out. This is homogeneously enhancing.
So either an astrocytoma or an Pandemona.
Good. So it's, as I discussed earlier, Pandemona, kind of just because it's more homogeneously enhancing. But yeah, Astrocytomas is not an incorrect. And then I'll kind of bump this one up. Ray, try to describe this lesion for us.
Okay, this one looks intramedullary as well, and yeah, it looks intramedullary. It's hyper intense on T2. It's hypo intense on T1, and on contrast imaging, it's partially enhancing, and I can see there's some parts that's not enhancing. So it's a heterogeneous lesion. So for something like this, I'm also thinking of like astrocytoma and Pandemona as my top two.
Okay, just to help you out too, there's a cystic area and then an enhancing area, and then on T2 you can see some flow voids. Would that change your differential?
Oh, cystic and flow voids. Yes, that will also make me think Angioblastomas.
Perfect, good. Again, very, very rare, but just kind of have it in the back of your mind. All right. And then Trevor, I guess describe this lesion. and then give us a differential.
Sure. On T2, we kind of see an intramedullary, hyperintense, diffuse lesion, most notably in the upper part of the core, but you can also see some extension down to the lower part of the cervical cord. On T1 post, it looks like you have some almost cystic enhancement of the lesions, and it's diffusely, heterogeneously enhancing as well. So for this, I would say our differential for an intramedullary tumor, most of it is going to be a spinal astrocytoma. We could also have metastases, and also on the differential would be things like a ganglio or pilocytic, but less likely. I think my differential my number one diagnosis would be the diffuse astrocytoma. Could also have something non-tumor if we were considering that as well, but given we're in a tumor section, it could be something like MS, but this looks more diffuse.
I'm really happy you said that because it is MS. So,
all right.
So always have that in the back of your mind. Again, boards loves to kind of make you think something's tumor and to biopsy it. So what kind of gives us the way is that it has these kind of different areas, that it's not continuous enhancement, they're kind of patchy areas that you can see even in the lower part as well. So I always have, just like you said, like non-tumor things in the back of your mind. But that's good that you came to that. All right. So questions. So this is an Pandemona. We're planning to do surgery. Alex, what kind of neuromonitoring would you want to use for this resection?
I would want to use, obviously, SCCPs, EMGs, gamma evoked potentials. I think also kind of special monitoring would be using D waves.
Perfect. Well, so you have all that set up. You're doing your resection. Is there any point when you're hearing with the monitoring, your MEPs and D wave is decreasing, that you would stop your resection?
Yeah, if I had more than a 50% drop in my motors, I would stop resecting at that point.
Perfect, nice. And where would you want to perform your myelotomy? A, B, or C?
Sorry, is this a cut of the actual tumor?
Yeah. This is enhancing tumor. Yeah.
Okay. I mean, there are a couple options. I would favor a midline myelotomy for this one.
Yep, exactly. That's the safest way. And then, how would you counsel the patient beforehand of expected potential deficits?
Given the extent of the tumor, I would counsel the patient that they very well might have some weakness, potentially some sensory loss following the procedure, but again, done safely. Most of the post-op deficits should resolve. This is most likely going to be due to cord edema, due to manipulation during the resection.
That's definitely correct. But I was trying to just getting more towards this proprioception and vibration sensation, just because you're going through the dorsal columns. But what you said is absolutely correct. You should talk about motor strength and all of that. But everything else you said is great. And I like how you emphasize the D waves, because that's the kind of the gold standard for intramedullary tumor resection. And just like you said, you should stop your surgery if those amplitudes drop less than 50% of baseline, and everything else said was great. And just to review for D-wave reporting, so this is done with basically two leads, one that goes cranial, one that goes caudal, and it produces stimulation of the spinal cord, specifically the corticospinal tracts, and then you can record them at the more caudal area to have the most precise kind of monitoring. And as I said, it's the gold standard. Its disadvantage is, you're usually putting these epidurally where you can't really see exactly where it's going, so it can make it difficult to lateralize. The electrode is in your field, which can kind of be in the way, but usually you can maneuver it so it's not, and you can't use it in children less than 4. All right, so I'll just go to a case that I did with Dr. Srivastava and Dr. Creedy last year. This is a 58-year-old gentleman, no past medical history, presented with left greater than right neck pain and C2 distribution. I'll show this imaging right here where there's T2 on the left side, T1 post on the right, so non-enhancing. And then to help you, guide you for your differential, here's flare here, but I guess more importantly, here's GRE. So Trevor, what would you say this is?
So it looks like an intramedullary tumor on T. If you go back to the T1, it looked hyper intense on T2, and then on the T1 post is non-enhancing, which would lead me to think that a Pandemona would be a high likelihood on a differential.
I'll kind of give it away, but the fact that I have this GRE right here is should hopefully give away what it is. It's dark on GRE.
Dark on GRE could have it could be a pilocytic or a hemangio, or it could be, calf mal.
Exactly. So we thought it was a cavernoma, basically based on this GRE cut. We talked about the differential. I'll kind of get moving on this because I want to get through some other stuff. So operative plan, what we ended up doing was a C1-2 laminoplasty, intradural exploration, resection of this intramedullary lesion. During the case, we had some transient fluctuations, but they were returned by the end of the case. And after the surgery, he just had mild hand grip weakness, otherwise was neurointact. And here's some OR images. This is before we opened the dura. Here's one of those D-wave catheters going caudally. Here's what it looked like before we incised the spinal cord. You can kind of see this vein draped over it that we avoided, and we got into it and looked like cavernoma, and we completed our resection. It was a very good case. Here's postoperative imaging, gross total resection, just a little air bubble in that area, but the patient did great. All right, so I'll move my talk to what we mostly deal with for spine tumors, metastatic. And so all the residents should be aware of the Patchel study, which was published in 2005. And this gave us good evidence that direct compression with surgery plus post-op radiation is superior to niche radiation. That's kind of guides us our management. And how we do it today is basically the NAMS framework, which gives us kind of a decision framework to how we treat each of these spinal mets. It's kind of made of these 4 components that we'll go through. So neurologic, so that's kind of more based on the tumor extent and invasion. We usually use this Bilski grade, which grades how much epidural spinal cord compression there is. Goes from 1A, B, C to 2 and 3, shown here, where 3 is basically total effacement, no CSF seen. Oncologic is basically the tumor's responsiveness to RT. So as we kind of talked about, the more favorable ones, lymphoma, melanoma, breast, prostate, whereas sarcoma, renal, melanoma are not really amenable to normal radiation. Next is mechanical stability, which we usually use the SIN score for, which helps kind of assess tumor-related instability. Like most spine grading things, there's a score that kind of helps guide management, where low number is stable, high number is unstable, and there's kind of this middle ground that's potentially unstable. And here's just a chart of that scoring, which includes its location, pain, what kind of bone lesion it is, whether there's kind of any associated deformity, vertebral body collapse, and then there's involvement of the posterior elements. And then to discuss the systemic disease, which is kind of overall prognosis and how extensive the tumor has spread for each person. There's different prognosis score systems. I'll just give you the one that I think has been found to have the most accurate predicting a full year survival, and that's the Tokihashi score. But there, like I said, there's plenty of other ones that you can help guide you. And it's basically just a different way to kind of assess how healthy the patient is and if they're going to survive surgery. So kind of putting this all together, you kind of use these 4 different factors to kind of help guide you, whether it's going to be just normal radiation or there's going to be stabilization surgery, what kind of radiation you use, and then kind of what type of surgery that you're going to do. And again, you kind of just do those different things to kind of help guide what your kind of surgical management is. Again, every patient's different, but this is kind of an overall grading scheme to how to do that. And to kind of just further discuss external beam radiation, this is more for the radiosensitive tumors, and it can be delivered to all structures in the field. Here's the kind of the normal fractional doses. And as we discussed, SRS is better for more radioresistant tumors because you can give a higher dose in single or 3 to 5 fractions. Separation surgery. So we do this for radioresistant tumors that we're going to require some decompression, and then we'll need radiation afterwards. And it involves minimal tumor resection. to separate the tumor from the spinal cord, so the bulk of the mass can then be further treated with radiation. And then briefly, stabilization options. I think everyone kind of knows kind of the normal things: percutaneous screws, open instrumentation. You can do percutaneous with cement, and then obviously a corpectomy if the anterior column is disrupted. And I'll finish with another case that I did with Dr. Creedy last year. This is a 64-year-old female, stage 3 renal cell cancer, presenting with back pain, worse with movement, and is neurointact. So this is her imaging. You can see here that tumor is invading this right pedicle at T12. And then higher up, it has pretty severe epidural components as well as tumor involvement for both of these pedicles as well. And I just showed a CT here that shows it's not really lytic or blastic in nature, and there's no real significant vertebral body collapse or deformity. Okay, so you have a tumor in the lower thoracic spine that you're planning to do, surgery for. Is there any additional workup that you'd want to do? Halima, how about you? Anything else? Any other procedures or imaging or diagnostic studies?
So we would definitely do for the overall like norms criteria, we need the prognosis. So like the stage of the we do like a full workup.
Yep. So I'm guiding you towards any type of further. We can discuss that, but imaging workup. Anything you can think of?
Lower thoracic.
Okay. What I'm basically getting at is you kind of want to, since you're doing surgery around these pedicles, you're going to want to identify where the artery of Adamskiewicz is. And that's obviously an important artery to help spare the person any kind of motor deficits that may have happened during surgery. Most commonly arises from T10 on the left side, but can have a variety of ranges. And it's usually a good idea to do a spinal angio for these cases to identify that. We actually did a spinal angio for both of those reasons to identify where Adamskiewicz was, and it was actually the right T9. And then because this is renal cell cancer, it's going to be bloody. We actually were able to have it embolized as well. And so going through the NOMS for this one, so neurologic, we see some epidural disease, pretty severe, but we do see some CSF. So this is grade 2. And the patient didn't have any myelopathy. This is renal cells. This is radio-resistant. In terms of mechanical stability, I kind of already went through this. And basically, we got a 9, which is potentially unstable. And prognosis, she was pretty healthy. Basically had a prognosis of greater than a year, which is good. And so we kind of have all these different factors together. And we kind of can help guide our management. So we get radio-resistant, potentially unstable. She's able to tolerate surgery. So the surgery that we did is basically a decompression stabilization followed by SRS. So what we did was a fusion study, T8 to L2. We decompressed the T10 pedicles bilaterally as well as right T11 and was able to remove some of that epidural tumor. And the case went really well. Patient did great. She was discharged on day 6, ambulating without any aids. And she did receive her post-op radiation and immunotherapy. And then her last office visit about 1 year ago was doing well with no pain issues, and she was doing well with her immunotherapy as well. That's it for me. It's a picture of my son playing with one of our screws, practicing his pedicle insertion technique. If there's any questions or anything, go with that.
Great job, Jeff. Any questions from the residents? Okay, let's move on to our next speaker. Jeff, can you stop sharing your screen?
Yeah, I'm trying to get out of this. Oh, there it is. Thanks.
Okay, next up, we're going to hear from Justin Granstein. He is a neurocritical care fellow here at Mount Sinai, and today he's going to be talking to us about neuroprognostication after cardiac arrest. Go ahead and take it away, Justin.
Can everybody hear me and see the slides right now? Is that a yes?
Yes, we can.
Yes.
Great, thank you. We're going to do some neurocritical care pearls today, focusing on neuroprognostication after cardiac arrest. Everyone who's been through the unit knows that it's something we see fairly frequently, and it's actually relatively common, but still in some aspects not particularly well managed or understood problem. For purposes today, the terms post-arrest anoxia, global anoxic brain injury, hypoxic ischemic brain injury, we'll use those sort of interchangeably. And it sort of comes to particular relevance for us because it's a widespread issue. There's about 300,000 in-hospital cardiac arrests in the United States each year. And obviously that says nothing of all the out-of-hospital cardiac arrests that end up coming to us. And I think it's also quite telling that almost 70% of in-hospital cardiac arrest fatalities are actually due to anoxic brain injury rather than primary cardiac death. So what is really happening when we talk about post-anoxic injury from cardiac arrest? We sort of focus on this two-hit model. The first part, the primary injury, is pretty self-explanatory. You essentially have disruption of cerebral oxygen delivery, not enough oxygen getting to the brain tissue. And then, of course, on top of that, you have primary cardiac injury or whatever other reason there is for the etiology of the arrest. Then the secondary injury, which can be just as harmful, if not worse, if not well controlled or addressed appropriately, is very multifactorial. And in the immediate post-arrest period, you're worried about microvascular dysfunction, vasogenic cerebral edema, oftentimes owing to that microvascular dysfunction. Both hyper or hypocarbia can be very harmful. And then hypoxia, of course, is something that we worried about. But so is hyperoxia, and I think that's something that gets overlooked quite often. And then the issue of hyperthermia is something that we'll discuss in a little bit more depth as well. So just as for most patients in the ICU or elsewhere, your initial impression is going to be your ABCs. You are going to make sure that you have adequate hemodynamic support. And then where things get a little bit different here is getting an EEG ends up being very important on these patients early on for seizure investigation and seizure control. And then we will do a little bit of a deeper dive into this question of temperature management, which has been a little bit of a hot topic for, I don't know, the last 20 years or so. But the takeaway here is that not all cardiac arrests are created equal. And that's something I think is obvious to most of us. And so this leads to a lot of questions around management, which in turn will affect our prognostication. Such a wide degree of heterogeneity in terms of temperature recommendations, not just for what the actual temperature should be, but what was the etiology? Was it a shockable or a non-shockable initial rhythm? Did this occur in the hospital or out of the hospital? Should we use external cooling devices or should we attempt an endovascular cooling method? And then was this a primary cardiac event? Was this primarily a respiratory event or was this a traumatic arrest? All of these play into how we're going to have to conceptualize the idea of cardiac arrest and how we're going to treat it, and then how we think we can prognosticate moving forward. three big pillars of cardiac arrest management and prognostication. The first is cerebral perfusion. And so clearly the ability to continue to pump blood and therefore oxygen to the brain is critical. But as we were discussing with our secondary injury, there's a very complex multifactorial injury cascade that's taking place here. So we have not only concern for the ability to maintain perfusion from whatever the etiology, especially in primary cardiac issues are. And that's going to be concerning after we get ROSC. Are we able to maintain adequate perfusion to the brain? But then once we are perfusing the brain, because of all the damage that's been done, presumably, as well as damage to the microvascular structures, the endothelium, then we are concerned that we've lost the ability to maintain autoregulation within the brain. And that's something that's critical and oftentimes overlooked. Additionally, ischemia to the vessels themselves causes a number of problems. The formation of microthrombi, the inability to provide adequate perfusion despite adequate pressures, and then the breakdown of these vessels in the endothelium can cause very leaky vessels. We start to see breakdown of the blood-brain barrier, which can give us some cerebral edema as well. And then on top of this, and sort of compounding it, we have the generalized cytokine invasion, and we have the inflammatory response, which can sort of tip us over the edge sometimes. And so it ends up being a bit of a balancing act between these different factors, and we have to keep all of this in mind. Temperature considerations, as I said, have been increasingly complex, and part of that owes to the wide variety of etiologies and presentations of cardiac arrest, as well as neurologic injury. But the idea of using temperature management is actually not a new one, going as far back as ancient Egypt with evidence of using the cold or cold mud for the treatment of burns and blisters. Hippocrates and the ancient Greeks used to take someone who was very ill and cover them in wet mud. And then whichever part of the body dried first was thought to be the hottest, and that was presumed to be where the disease was. And so cold would be applied to that part of the body to try and treat the disease. In the 16th, or I guess 17th to 18th, 19th centuries, we started to see more reliable reports of cold-induced survival, some animal experimentation. Most of the time, these were drownings, not surprisingly, but also some reports of people who survived hangings after being kept at low temperatures, which may say more about the hangman than the use of therapeutic hypothermia. But it wasn't really until the early part of the 20th century where we started to see the intentional and useful application of hypothermia for medical purposes. And Dr. Temple Fay was the first really to protocolize it. And he initially started using hypothermia as a treatment for cancer. Taking the observation that metastatic tumors are rarely at the distal ends of the limbs because they must be colder, so they don't grow as well there. He actually even invented sort of an early precursor to the Arctic sun device, and had what he reported was some degree of success in prolonging life with that. By the latter half of the last century, we sort of accumulated better evidence that lower body temperature decreased metabolic rate, and that also played into a lower cerebral metabolic rate. And it was at the very end of the 70s and really into the 90s where intraoperative hypothermia was starting to be used in complex cardiac and neurosurgical cases to decrease the risk of low perfusion injury to the brain. And then in the 90s, we started to see real interest specifically in the use of therapeutic hypothermia for neuroprotection, both in TBI, the treatment of intracranial hypertension, and then anoxic and post-arrest injuries. So we'll fast forward a little bit to 2016. And over the last 20 years, for every study that you find that says 33 degrees is the right temperature, you'll find one that says 36 is even better or just as good. Some will say 48 hours of cooling, some will say 24 hours of cooling. And so one of my favorite resources, the Cochrane Group, put together a systematic review meta-analysis of several of these trials. And as of 2016, what we see essentially is that cooling to 33 degrees in post-cardiac arrest patients for the purpose of neuroprotection is statistically superior to no cooling at all. And then unfortunately at the time, they were only able to find one high quality study to compare 33 degrees versus 36 degrees. But at that time, what we saw essentially was that there was no difference between the two temperatures. So the idea was, cool them a little bit, cool them a lot, but it should be about the same, and it's better than doing nothing at all. Then in 2019, the New England Journal published this paper with about 600 patients in a prospective randomized trial, which demonstrated, wait a second, we have the normothermia group, which here was actually 36 versus a 33 degrees in the hypothermia group. And there was actually significantly better outcomes in the full hypothermia group at 33. So maybe that's what we should be doing with these patients. But then a few months later, in 2019, we had another prospective registry trial come out. This was a little bit less, fewer than 200 patients. But the takeaway here was that as measured by cerebral performance category score, which is a common neurologic outcome tool, again, they're not noticing any particular difference depending on the temperature, either in intention to treat or as treated analysis. And so again, this was sort of just a very open question as to exactly how to treat these patients and what would give us the best possible outcomes. And then just earlier this year, in March, right before we were distracted by the coronavirus, another randomized trial came out. Excuse me, it wasn't randomized. This was a before and after protocol study at a single center with about 600 out-of-hospital cardiac arrest patients. And what we saw here was reinforcing the idea that full temperature management down to 33 degrees would actually produce better neurologic outcomes than sort of the targeted temperature management to only 36 degrees. I think, this obviously is still an area of active research, and the real point, the real takeaway here, I think, is something that we're seeing also in the TBI literature, but essentially the idea is avoid fever at all costs. And I would say the weight of evidence probably weighs a little bit more heavily towards targeting a temperature of 33 degrees. But I think it would be difficult to fault you for going to 36 if you're able to avoid fevers in these patients. And the third pillar of this resuscitation is going to be metabolic stress. You can sort of pick whichever schematic you want to illustrate all the different ways in which cells are damaged in the ischemia and then the reperfusion, primary and secondary injuries. It's a complex pathway with a lot of moving parts, but really the areas where we are able to or attempt to make the greatest interventions are these. So during ischemia, obviously, the disruption of the electrochemical gradient when you lose oxygen perfusing or when you lose oxygen delivery to the cells, you have decoupling of the electrochemical gradient, you lose the ability to do oxidative metabolism. And so the best way to treat that obviously is to get perfusing and perfusing rhythm, excuse me, as rapidly as possible to achieve ROSC, which is what we do every time, obviously. Then after you've achieved ROSC, as I mentioned before, avoiding hyperoxia and the accumulation of oxygen-free radicals and other free radicals, which can damage the mitochondria in the cells. is going to be an important concept for managing your secondary injury, as well as maintaining that adequate cerebral perfusion. And all of this, obviously, the end goal here is to avoid death of mitochondria in the cells and cell death itself. This, I think, is a point that gets overlooked a little bit from time to time in intubated patients, and is particularly relevant to our post-arrest population. Oftentimes we'll see patients who get intubated and they come up to the ICU from the ER or the OR, and more typically either from another hospital or from the ER. And it's someone who is intubated urgently or emergently. Sometimes it's because they were herniating, sometimes it's because they arrested, sometimes they were just altered from seizures. And they come up to us, it's an average sized person, and they were intubated, sitting downstairs for a couple of hours. And they're given to me on a tidal volume of 500 with an FiO2 of 100% at a rate of 20. And you can draw gas and they're going to have a sky high PaO2. In patients post cardiac arrest who are high risk of anoxic brain injury, and I think by a relatively reasonable extrapolation, patients with other reasons to have at-risk brain tissue, not just from post-arrest, this is actually a real concern. And there's a study, as I'm demonstrating just the forest plot here, which is showing us the increasing relative risk of poor neurologic outcome by PaO2. And so here the definitive cutoff is a PaO2 of 300, which then confers an elevated risk of poor outcome for these patients. And tracking out all of these patients by every time point, it works out to about a 3% per hour increased risk of poor neurologic outcome with PaO2 over 300. But you can see that there's a clear trend starting around 250. So I would say that once your PaO2 starts to hover around 250, you really got to reevaluate what you're doing for these patients. Now, especially in our population, the oxygenation typically, I think, is not the biggest issue. We don't deal with as much primary pulmonary disease as we do people who are intubated for other reasons. As I said, either because they're herniating or they're altered or they're seizing. And so once the airway's been secured, we should be able to relatively rapidly get people down to an FiO2 closer to 40, 50%. And then again, we always have to keep in mind what tidal volume and rate we should be having our ventilator set to. Just reinforcing that from the same study, the effects of hyperoxia were seen both in early neurologic injury, which I believe was measured at ICU transfer or discharge, and then also poor neurologic outcome long-term, which was at about 6 months. And so that's a pretty significantly increased risk of injury, and that would be an iatrogenic injury. So people who are potentially on the cusp of some sort of recovery or have tenuous at-risk tissue, we'd run the risk of pushing them over the edge sometimes. When talking specifically about prognostication and neuroprognostication following arrest, the Neurocritical Care Society has sort of divided your risk class into low, medium, and high. And rather than go through each of these in their totality, I think it'll be easier for us to look at the individual components of how we arrive at assigning somebody a risk for their prognostication purposes. And so we'll do that now. So the first modality, so to speak, of making your prognosis for these patients is going to be your cardiac downtime. And this is not something that I would consider a modifiable modality once the patient arrives in the ICU. But essentially, you're looking at 2 time points. The first being the no-flow interval, which is measured as the time of arrest to the time of initiation of CPR, whether it be bystander, in hospital, etc. So a no flow interval less than 3 minutes is thought to confer a relatively low risk. And we use risk in this term to mean risk of poor neurologic outcome. 3 to 8 minutes, low to medium risk, and more than that would be high risk. This can be confounded because, especially in the out-of-hospital arrest patient population, many of these are unwitnessed arrests, and we have an unknown downtime, which can make things more difficult. And then other things such as cardiac medications, sedatives, atherosclerotic burden can impair perfusion and the effectiveness of CPR as well. So it's not always entirely clear how well this folds into your predictions. And then in addition to the no flow interval, you have the total ischemic time. And so this is determined as the time of arrest measured out to the time of ROSC. So there's sort of a simple cutoff here of 25 minutes, which will delineate your low to high risk categories here. Again, there are going to be confounders such as the quality of CPR, but there's not much we can do about that, especially for the out-of-hospital population. The next part of your prognostication is going to be based on your exam. And previously, in the pre-hypothermia targeted temperature management era, the GCS motor score was used relatively frequently. These days, we're using more of the 4 score, specifically looking at the brainstem, which is going to give you your corneal and pupillary reflexes. And so a 4 score of 0 to 1, and that's the full outline of unresponsiveness scale. And so 0 to 1, indicating absent pupillary and corneal reflexes, is considered to confer a high risk of poor neurologic outcome. And again, all of these modalities that I'm going through, this is for early prognostication, which is measured within 12 hours of arrest. Imaging, in my opinion, tends to not be quite as useful as maybe we would expect. And so per Critical Care Society guidelines, you get a CT of the head at the time of ICU admission, and then you look for the degree of effacement of the gray-white junctions in the cortex. And that is measured by a ratio of Hounsfield units greater than 1.2, comparing the cortex to the deep gray structures. There's a little bit of confounding here in terms of quality of imaging. If you're able to measure the Hounsfield units, that should sort of get rid of your inter-rater reliability, hopefully. But I think the timing here is pretty critical. So a CT of the same post-arrest patient is likely to look very different at 1 hour post-arrest as it would 6 hours post-arrest. And so I would actually argue that getting a head CT in the immediate post-arrest period, the first hour or so, unless there is significant concern for an intracranial process that may have led to the arrest, may not give you as much data as you would get from one a little bit later on. And then the question of MRI comes up as well. And again, this is something that I find is much more helpful looking a little bit later out, especially in communicating with families, not only of the question, will he wake up, will he get better, but if he or she wakes up, if he or she, is able to survive this, what kind of deficits and quality of life can we expect? And that's really where I find the MRI to be most useful. And then EEG, and I'm going to throw a couple of different pieces here together, but EEG, looking at the background, if you can get it applied within the first 4 hours after ROSC, can actually be quite helpful. And so a reactive or continuous background on your EEG is a relatively favorable prognostic sign. A non-reactive EEG, seeing somebody in burst suppression or a completely isoelectric EEG, all confer a very poor prognosis. Now, especially in these patients who are likely to be intubated, sedated, potentially paralyzed, the EEG is going to be extremely sensitive to confounding based on those medications. But at the same time, regardless, unless you have somebody in a barbiturate coma, you really shouldn't be seeing an isoelectric EEG. So similar to the physical exam, this is something that's going to be potentially very confounded by the medications, but it's a balance, obviously. I will touch on seizures just briefly. It's definitely an area of active research and discussion in this field. The significance of myoclonus post-arrest, the timing of the myoclonus, whether or not there is EEG correlate, whether or not that EEG correlate is localized or diffuse, the frequency of epileptiform discharges. Previously, it was thought that early myoclonus was a very poor prognostic sign, and I think there's some evidence that it may be, but we're seeing, more and more that may not necessarily be the case. So basically, it's not a perfect predictor, and I think again, it's something that is hard to be a definitive determinant in prognostication. We just don't really know, I think, enough about it and about how it plays into different types of cardiac arrest, the timing, whether it's cortical or subcortical. And so that's really, I think, a discussion for a more extended time period. But suffice to say that the general teaching is that frequent seizures, especially someone who's either in convulsive or non-convulsive status following cardiac arrest, that's thought to be a very poor prognostic sign. And then somatosensory evoked potentials is something we don't yet do for our post-arrest patients here at Mount Sinai, but something that I used previously at another institution. And there's actually, I think, very good evidence and also anecdotally from my experience, very good correlation between your N20 SSEPs and your outcomes. So bilaterally absent N20 SSEPs tend to correlate very strongly with the poor neurologic outcome. I also just want to give a quick word on biomarkers because this comes up from time to time, and we always are sort of looking for easier ways to investigate things. The S100 and the neuron-specific enolase are biomarkers that have the advantage of being drawn from the serum. You don't need CSF for them. I think the NSE may even be in one of our arrest protocols here. They both also have their issues. So I would say both of these potential biomarkers have pretty poor sensitivity, I think between 50 and 60-ish percent. But they are very specific, which is good. Neuron-specific enolase in itself has a lot of controversy, not only about the cutoff values, which are not very well defined. In fact, there's literature to suggest that your values vary widely from the same patient on the same sample when measured at different labs. But the issue is how to interpret the results. So the standard protocol will be to measure your neuron-specific enolase at 24, 48 and 72 hours. But there's a lot of debate over whether or not it's an increase in your NSE level that is indicative of poor outcome, whether or not it's the absolute value, whether it's the magnitude of increase or decrease, or whether you should be comparing the time points 24 hours and 48 hours or admission in 24 hours. So I'd say this is a pretty unsettled issue, but it's something that I wouldn't put a lot of confidence in, again, as a specific determinant of your prognostication. And then lastly, CKBB isoenzyme is a biomarker that requires CSF. So at my previous institution, most of our post-arrest patients would get an LP. The data on this is a little bit older. It is not, to my knowledge, been reassessed in the era of widespread temperature management for these patients. And so I am not entirely sure that the validity of the prior studies holds. Similar to the S100 and the NSE, has a relatively poor sensitivity, but a very high specificity. But where it shines a little bit is that the combination of your absolute CKBB level with your SSEPs can push your prognostication sensitivity to about 80%, which is better than any of these biomarkers just on their own. And then just briefly, this is a diagram demonstrating how things have changed significantly in the era of temperature management or hypothermia. And we went over much of this before, but even just different from early prognostication, looking at sort of the extended 72 hours, which was more standard, your false positive rate tends to increase for some of what had been our standard markers and prognosticators. And so, on the one hand, that says, well, maybe that's good. We're obviously doing something that's improving outcomes, but then it just makes our actual predictions all that much more difficult, unfortunately. So I would say take-home points for management of these post-arrest patients. Obviously, we want to achieve ROSC as quickly as possible. We need to be aware that we don't have the luxury necessarily of maintaining cerebral autoregulation. It's extremely important to avoid hyperoxia and hyperglycemia in these patients, both of which have been shown to worsen outcomes in anoxic brain injuries. And while again there's ongoing debate over the best temperature regulation for these patients, my personal feeling would be that I think the weight of evidence leans slightly more towards a cooling to 33 degrees as opposed to 36. But in any event, I would say that the most important thing will be to avoid hyperthermia, avoid a fever in these patients at all costs. And then when we're prognosticating, it can be something that takes a little bit of time. It requires patience, which can be frustrating and somewhat unsatisfying sometimes for us as the provider team, as well as for the families and loved ones of our patients. But I think it is very important to really not to make any big decisions in the first 24 hours. And I would even say in the first 24 hours after the patient's been rewarmed if they were cooled, which can obviously extend our timeline out to days. But we don't, unfortunately, have the tools that really give us a clear-cut issue. And the way this was explained to me was, we can get pretty good at predicting poor outcomes, but we're not very good at predicting good ones. And I think that still holds true, unfortunately. In terms of imaging, as I said before, I would delay the CT a little bit just to get a clearer picture and something that I think would be a little bit more accurate. EEG, I think, is going to be critical for these patients. You get that on them as soon as possible. SSEPs, if they are available, usually between days 2 and 3. MRI can be useful, especially, as I mentioned, for the extent of damage and the disability burden, but I think is not something that has to happen in the first 24 hours. Biomarkers, I would be wary of them in these patients. I think you can use them as supportive evidence with the appropriate context. But if you have a very muddied picture with an unclear etiology, a nonsensical exam that's confounded by your medications, a relatively middle-of-the-road EEG, I would not base decisions on goals of care or treatment plans for these patients based simply on the biomarkers. I think they're just not there yet. And then, of course, serial neurologic exams are going to be important in these patients. Again, hopefully you can get them on sedation holidays as possible. But really, I think the big three for these patients are going to be your SSEPs, if you can get it, your EEG, and then your serial exams, as is true for most patients in our unit. I will be happy to stop there and take any questions from anybody.
Thanks, Justin. That was a great talk and a lot of useful information there. In terms of the temperature management, I've heard recently about some of the suspended animation studies that they're doing, particularly in post-traumatic cardiac arrest, and I think it's probably a fairly new area of investigation. I think Maryland Shock Trauma suspended their first patient late last year if I'm not mistaken. Are you aware of whether there are any ongoing studies of a potential role here in terms of preserving post-cardiac arrest not related to trauma using sort of hyper extreme temperatures below this 33?
I'm not actually aware of any literature using that in the post-arrest population. I believe in the, I want to say 80s and 90s out of Case Western, there was a good amount of literature on colder temperatures as well as inducing cardiac standstill in patients who are either undergoing complex cardiac surgeries as well as open surgeries for the repair of complex intracranial aneurysms as well. So I think there's some literature there, but to be honest, I haven't gone very deeply into that.
Okay, and is 33 as a floor? I mean, are we just not seeing, was that chosen arbitrarily, or is it just difficult to cool below 33?
It can be difficult. It certainly can be done. I think, you know, the colder you go, the higher the risk you're going to run of cooling related complications, such as immunosuppression. A lot of these patients end up getting infections or sepsis from other causes as well. You end up causing a lot of coagulopathies, which in patients who are just arrested, obviously is something you want to avoid, especially if you're already having some microthrombi formation in the cerebral vasculature. And then shivering in the body's own sort of rewarming mechanisms, if they're intact, are actually at times very difficult to combat. And so, you know, I think that's why we've found 33 to be a relatively happy medium there.
Thank you.
Any other questions from any residents or anyone who's an attendee? And if you have a question as an attendee, you can raise your hand. Okay. Thank you very much, Justin. We really appreciate it. Great job.
Absolutely. Thanks for having me.